Victor. Let's go ahead and start recording, please.
Okay. All right.
All right. Wonderful. Good morning, everybody. Thank you for being here. We are very excited to have Dr. Brian Wood here to speak with us today. Dr. Wood is a professor of medicine in the Division of Allergy and Infectious Diseases at the University of Washington, and he is going to give us a talk on the future of ART, two-drug oral and injectable therapy. So, Brian, thank you so much for being here.
Morning, everyone. Thanks for having me back. I really enjoy doing this every year and appreciate the conference organizers. I also want to give a special shout out and thank you to Carlos Flores if he is watching. I had a computer meltdown yesterday and Carlos saved my slides for me. He worked some magic. So really appreciate everyone being here. I am generally asked to talk about new and upcoming antiretrovirals. I think you will see why I am focusing on two-drug therapy this year. I want to be clear that I have no financial interest in any of the meds I will be talking about, and I will discuss investigational therapy. I'm going to do my best to use generic names. I know because we're talking about ART, this may seem a little more focused on prescribers, but I will try to come back to general themes and bring it back to messages that hopefully will be helpful to everyone. I will have a couple of poll questions and I will ask you a couple places to weigh in the chat box. So please don't be shy. I will do a brief review of the latest guidelines, talk a little bit about initial ART. There are a couple outstanding questions and some new data on starting, or let me say which therapy to start as initial ART, but a lot of this we'll talk about switching and what's coming. And I think it is fascinating that all of the new oral options in development are two-drug therapy. I am not aware of a three-drug oral ART regimen currently in the pipeline. Even the long-acting or non-daily therapy is generally two-drug. I really am having trouble thinking of or finding exceptions. Let's start with a case to get everyone's mental wheels turning this morning based on a real case. Victor, I believe you can open a poll for us. Thanks so much. So here's the case. Relatively recent, few details adjusted, but general idea here. This is a 55-year-old patient who was recently diagnosed with HIV. It was part of a workup for a very low platelet count. There was a genotype done by the fantastic primary care provider who made the diagnosis. There is no resistance on the genotype. The CD4 count you can see is 112, relatively low. The viral load is relatively high. It is confirmed there was no chronic hepatitis B infection. This individual is quite worried and wary of potential side effects, but willing to start ART. What would you recommend? This person says, I'll take what you recommend. Give me something that is the least likely to have side effects. Victor, maybe we give that about 5 seconds.
Okay.
Let you close it when you think we're ready.
Okay, I'm going to go ahead and close it.
Okay. So bit of a spread, but clearly the dominant answer, bictegravir/taf FTC. I got a couple votes, one vote for dolutegravir/taf FTC, 4 votes for dolutegravir/lamivudine, which I find interesting. Couldn't get anyone to go for the boosted darunavir, even though there's a low CD4 count and a high viral load. And I think this shows a little bit of how our understanding has shifted. I will tell you, what I started was bictegravir/taf FTC. I wondered, though, about dolutegravir/lamivudine, and I feel like that would be a very reasonable option. Honestly, I think all of these would be reasonable, but I'm going to try to show you why I think dolutegravir 3TC or dolutegravir/lamivudine would be fine, especially for someone who is wary of side effects, especially for someone who does not have hepatitis B. These are the latest guidelines for what to start. I chose the IAS USA guidelines, but they are in line with the HHS guidelines. These were updated just slightly later, but they are really the same for most people starting their first ever ART regimen. The options here listed in alphabetical order will be bictegravir, TAF-FTC, trade name Biktarvy, dolutegravir, trade name Tivicay, with TAF-FTC, that's Descovy, or TDF-FTC, that's Truvada, or generic versions. Dolutegravir 3TC or dolutegravir lamivudine, trade name Dovato, still has these caveats. Only recommended if viral load below 500,000, only recommended if you have documented genotype results and no 3TC or lamivudine resistance and no hepatitis B. I am not convinced we need to follow that viral load threshold, and I'm not convinced we really need to wait for a genotype result. I am convinced we need to make sure a person does not have hepatitis B. A reminder that this presumes a person has not had integrase inhibitors in their past, either for PrEP or recent PEP. If a person has received cabotegravir for PrEP in the past, then we would add an integrase genotype at baseline. And if starting rapidly, would use a boosted derivative-based regimen. That's really the only exception to this. The guidelines are clear if someone acquires HIV while taking oral PrEP. And Victor, you may not be muted at the moment, probably because you did the poll. Just FYI, thank you. If a person acquires HIV with oral while taking oral PrEP, TAF-FTC or TDF-FTC, then these options are very reasonable. Remember the caveat about prior integrase exposure, and that is really a rare setting in which we would add an integrase genotype to baseline resistance testing. But let's talk about this study. We recently reviewed it at one of the Madison Clinic Journal clubs. This is relatively recent, published in August. These investigators really wanted to ask the question, would dolutegravir lamivudine, I'm going to abbreviate it as D2G3TC, be as effective as three-drug therapy in the setting of advanced HIV defined by a very low CD4 count? The reason this was an important question is we just didn't have a lot of data. In the initial studies of dolutegravir 3TC as initial therapy, the number with low CD4 counts was quite low. There was a suggestion that dolutegravir 3TC might not be as effective as three-drug therapy, but again, numbers were low, and that difference was not due to virologic failures. So this is an important study. You can see here the entry criteria, the key one being CD4 count below 200, and you can see the exclusions there. Individuals in this trial were randomized 2-to-1 to receive either dolutegravir lamivudine, that's dolutegravir 3TC, two-drug therapy as their first ever regimen, as compared to dolutegravir with two NRTIs. I just want to highlight a few baseline characteristics. If we look in the blue at the dolutegravir lamivudine or dolutegravir 3TC two-drug initial therapy arm, you can see the median CD4 count was 109. You can see that a fair proportion had a CD4 count below 100, and a relatively high proportion had high viral loads as well. Over 60% above 100,000, 23% above 500,000, and over 10% with a viral load above 1 million copies. And you can see here the key results. Overall, in the blue bar, you can see the dual ART, the dolutegravir 3TC, compared to in the green bar, the three-drug therapy. Very equivalent virologic efficacy when looking at viral load below 50 copies at 48 weeks. You can see an equivalent number with viral load above 50 at 48 weeks. Most of these were relatively low viral loads, and the difference, those for whom you can't see data here, are simply missing data because this was intention to treat. 82 and 80% are relatively lower than what we see in a lot of trials for initial ART, but if the missing data were included here, if you did a per protocol analysis, it'd be closer to 90% and closer to what we generally see. The efficacy was similar for participants with a baseline viral load above 500,000 or even above 1 million, but obviously numbers were lower. There was no treatment emergent resistance in either arm. And we've seen some other smaller data that tends to agree with this. So again, dolutegravir lamivudine two-drug initial therapy, as long as someone doesn't have hepatitis B, is expected to be effective. I'm going to leave my trend of focusing on two-drug ART just to alert you to this study that we also saw this year at CROI. This was a multi-center study that really tried to answer the question of for advanced HIV, is a protease inhibitor-based regimen better or is an integrase inhibitor-based regimen okay? This question had been lingering in many minds. You can see here how advanced HIV was defined. Overall, participants in this trial had relatively low CD4 counts, relatively high viral loads. And I'm not going to belabor it. I just want to give the punchline that bictegravir TAF-FTC did quite well, even in the setting of very advanced HIV, low CD4 counts, opportunistic infections, and other markers of advanced HIV. This is the proportion of participants with a viral load above 50 copies at 48 weeks. Bictegravir TAF-FTC actually did better than boosted darunavir. They looked at a number of endpoints in this trial, and the overall message is that integrase inhibitor therapy seems to be as effective as boosted darunavir-based therapy, even in the setting of advanced HIV. I present that because it has been a relatively lingering thought that maybe a boosted PI would be better in that situation. But really, I'm going to focus the rest of the talk on switching and on new therapies that are coming and coming relatively soon. I'm going to ask you to weigh in on another case, another poll question, and then I really love your thoughts on the future of ART. I'll show you the trends. I will show you what's being prioritized. Just food for thought. I'm planting the seed now. Do you think the trends and the priorities for the future are really what should be prioritized? Do you think there should be a different priority with future ART? But let me just start by asking this question, again, based on a real case in my clinic. I will ask your opinion. Victor, if you don't mind pulling up the poll. That's a weird way to say that. If you don't mind opening the poll again, that'd be great. And I'm just going to ask everyone to weigh in. I don't think there is one right answer here. So this is a 55-year-old patient of mine. She is from outside the US. She has a long-term suppressed viral load on the regimen you can see. So a four-drug regimen because of past documented resistance. She is taking the integrase inhibitor dolutegravir, the NNRTI doravirine, and the NRTI's TAF-FTC. She really wants to simplify. She takes meds for other things as well, and she really just wants simpler, less pills. And you can see her past resistance there, NRTI resistance, and a K103N, which was from prior efavirenz, virologic failure. She does not have hepatitis B. I'm going to keep hitting home how important that is and how it's going to become even more important as we get away from TAF and TDF-based therapy. She returns to her home country several times a year for about a month at a time. And again, her priority, her primary priority, again, that's a weird way to say that. Her principal priority, her biggest priority is fewer pills. So what would you do? What would you recommend? Switch to bictegravir TAF-FTC, switch to injectable cabotegravir rilpivirine, switch to dolutegravir lamivudine, two-drug therapy, switch to dolutegravir rilpivirine, two-drug therapy, or wait for new options. There's no right answer here. Victor, I'll let you decide when we have enough responses.
Okay, let's do 5 more seconds. All right. Show results.
Okay. I mean, this really shows me that there is no one right option here. Thank you all for weighing in. The switch to bictegravir TAF-FTC, I think, would be very reasonable in the setting of this NRTI resistance and a long-term suppressed viral load. I would have no concern about that. The injectable cabotegravir rilpivirine should be effective. There's no resistance contraindication here. There's no hepatitis B. I think obviously we'd need to chat with her about the travel and making sure to come to injection appointments on time. And every 2 month injections might work out. I actually think dolutegravir 3TC or dolutegravir lamivudine would be reasonable here, and I'll show you why. I think dolutegravir rilpivirine would also be very reasonable. There's no resistance that would preclude it. And I think waiting for options that will be here probably within the next year, within the next 1 to 2 years, I'm pretty sure, would also be reasonable based on her priority. So I'm actually going to try to show you why I think all of these options would be reasonable. And I would base it on a discussion with the patient about her biggest priorities with therapy. I will come back to some additional considerations in talking to her more. A couple of things she really wanted. One was she was feeling really distressed about her weight. And so we talked about the potential or the data for switching to improve weight. And I'm really not convinced that a switch of ART is appropriate for that goal. I'll come back to that just a little bit at the end. She also talked about how when she travels, she really does not want to have bottles of pills with her. She really does not want family and friends in her home country to see bottles of pills. So we have an ongoing discussion about cabotegravir rilpivirine, and I think that is a really valid reason to consider it. Again, I think it is fascinating that the future of ART, the ART in development, is primarily two drug options. I'm going to show you a little bit of recent data for dolutegravir lamivudine, one of the current options. I don't have any new data on dolutegravir rilpivirine. I looked and there just wasn't much new, but it is sometimes a reasonable option. I would say that these days, in the absence of hepatitis B, dolutegravir lamivudine, this option has really become my most frequently prescribed option for switching therapy. This study came out last year. We talked about a different study of dolutegravir lamivudine with a history of M184V. This study and others all seem to be consistent in finding that dolutegravir lamivudine maintains virologic efficacy even with a historical M184V mutation. This was an open label single arm study, so a little bit more limited than the study we talked about last year, but this is what was new. These were adult individuals with suppressed viral load, a confirmed or suspected historical M184V or I. Most of them had a confirmed mutation on a past RNA genotype. They had relatively good CD4 counts, no resistance that would affect the dolutegravir, and all switched dolutegravir lamivudine daily. I've given you only a very brief description of the participants, and you can look into more data if you want to see. The publication, which just came out in October, is below. And overall, the message is a switch to dolutegravir lamivudine did just fine with individuals with suppressed viral load with a historical M184V mutation. The other thing that I think is really interesting and a really important message, and this came out in the trial we talked about last year too, is investigators did proviral or DNA or archive genotype here, again, for individuals known to have M184V mutation on past RNA genotypes. And the proviral resistance testing only found that M184V in 20%. The study we talked about last year called Solar 3D, they only found the 184V in 37%. So this is pretty consistent, even with a known past resistance mutation. The proviral genotypes only pick it up in 20 to 50% of instances. Message being a proviral genotype that does not show resistance does not rule it out. If it finds mutations, you can probably hang your hat on that. If it doesn't, you still have to consider it could be there. This is one of the reasons I send this test incredibly rarely, only if it is really going to change my clinical management, and always with a grain of salt that it may not find all the mutations. I'm going to give brief updates on cabotegravir rilpivirine. I want to mention a couple of studies that are coming, and then I'm going to tell you more about new agents coming in the relatively near future. Happy to field questions as well. And again, I'm going to ask you your opinion about a couple of things. First, with cabotegravir pivirine, I think we have learned a lot. I'm going to spend a moment on how counseling often goes for me in instances in which a person has been able to take their oral ART as prescribed and is interested in the long-acting injectables, perhaps due to convenience, again, perhaps to avoid needing bottles of pills at home or for other reasons. So I often counsel individuals about benefits, which I think will be obvious, like non-daily therapy, coming in for injections every 1 or 2 months instead of taking oral meds, reduce stigma, avoiding keeping meds at home, improvements in pill burden, improvements in pill fatigue. I heard Peter Shallett make this point recently, and it really stuck with me. It also allows a person to keep all of their HIV treatment compartmentalized in the clinic. They don't bring any of their treatment home. And for some individuals, that can be incredibly both important and empowering. However, when I sit and talk to people about injectable cabotegravir pivirine, talk about coming into the clinic every 1 or 2 months for the injections, potential pain with the injections, a small risk of virologic failure, even with on-time injections, I do have a fair number of people who tell me, I'd rather just take my simple oral ART at home, come in every 6 months. I'm really fine with what I'm doing now. But I think it is an important discussion. If you have other points you counsel people about, I would love to hear that. Please feel free to weigh in the chat box. I'll keep an eye out on that. Would just love to hear how your counseling goes, or if there's any other points you talk to people about. I think what we have learned even more about is the potential benefit and efficacy for long-acting cabotegravir pivirine in the setting of a detectable viral load. I've heard David Spock describe the, let's say, categories of individuals who might benefit from long-acting injectable therapy as, one, those individuals who have really succeeded with oral ART, with suppressed viral loads, without a lot of adherent support. And those were the individuals in the randomized control trials, the registrational trials that led to FDA approval of this option. Then let's say category 2, there are individuals who have succeeded, maintained suppressed viral loads, but with a lot of adherent support, a lot of outreach, a lot of alleviated adherent support. And then there are the third category of individuals who, despite all of the support, all of the outreach we've been able to provide over the years, have not succeeded in taking oral ART as prescribed and have had persistent detectable viral loads or persistent virologic failure. And so I think that clinics have to decide which group to prioritize. And I think a lot of clinics now are prioritizing that third group, individuals who just have not succeeded for years in taking oral ART as prescribed. And what we've learned is that this option can be incredibly powerful and can help individuals achieve suppressed viral loads, even if they haven't for years or even if they never have. I'm not going to go through all the data, but this systematic review that was just published in July, I think is really worth looking at. It's limited. There were a couple studies it did not include, but it included a lot of data. And you can see here the cumulative probability of viral load suppression. There was a bit of a range, but it's probably somewhere in the 87 to 92% range. This systematic review and meta-analysis, which again, I'd encourage you to look at, brings up a couple of unanswered questions. In the setting of a detectable viral load, should injectable cabotegravir pivirine be given every 1 month until viral suppression, or is every 2 months okay? The studies have varied on their strategies. There have been a couple of trials or descriptions of injectable cabotegravir pivirine with a detectable viral load that used every 2 month dosing, but a lot have not. This review also describes questions around how frequently viral load should be monitored, whether, if this option is not successful, whether drug levels should be checked, and then what is the best oral ART if a person develops virologic failure on this option. I also think it's really interesting that many individuals can achieve virologic suppression after virologic failure on cabotegravir pivirine, even if they develop new integrase or new NNRTI resistance. Of course, this involves being able to take the new regimen as prescribed, but the new regimen can be lenacapavir based. Sometimes it is boosted darunavir based, or there is growing data that even with virologic failure on this long-acting option, and even with new integrase inhibitor resistance, going back to or going to bictegravir TAF FTC is often effective. That may be a bit surprising. It may not be intuitive, but I think the key there is that integrase resistance mutations really compromise viral fitness. And we've learned a lot over the years that even with integrase resistance, a resumption of bictegravir TAF FTC can be effective if a person takes it as prescribed. So I think we'll see more data and more descriptions of the best ART options after virologic failure on long-acting therapy in the future. Excuse me. The HHS guidelines and also the IAS USA guidelines now include a mention of the possibility of injectable cabotegravir pivirine in the setting of a detectable viral load. And you can see here the way the HHS guidelines describe it. And then I want to put in a mention and a plug for the Crown study. I know our team is involved. We are a site. I believe Dr. Audrey Lee is our key point person. And I think we will get really important data from this study. Excuse me, one moment. Also, my dog is whining in the background, so apologies if you can hear that. I mentioned this last year, and I won't go through all the data, but again, I'm using this as a trigger to alert you to coming studies. So this is a description of lenacapavir with cabotegravir, two-drug injectable therapy, sometimes given with rilpivirine, sometimes without, in a relatively small number of individuals who had detectable viral loads, some of them very high viral loads. And you can see here the list of reasons why individuals received the long-acting every 6-month subcutaneous lenacapavir with injectable IM. With injectable IM cabotegravir, you can see here the list of reasons. You can see virologic suppression was relatively high. And in this paper, there was a call for a clinical trial. Thank you, RBI, for alerting me to this. And we will be a site for this first study as well, called PALACE. People with active viremia treated with lenacapavir and cabotegravir for effectiveness. I do not know the opening date, the start date for this trial, but it is coming. And then hopefully there will be a trial internationally as well of this same combination for individuals with virologic failure on TLD, which is TDF, lamivudine, dolutegravir, now the most commonly used prescription in lower and more middle income countries. So stay tuned for more data. Obviously, there are a lot of barriers to approval and acquisition of long-acting injectable therapy for people with HIV. I won't go through all of these, but I think a lot of them will ring true for you. There are others in our clinic who could speak much more to this than I can. There have been descriptions, including a very recent one you can see at the bottom, that describe both the barriers and potential interventions to solve them. Okay, we're moving along great. Again, please feel free to put questions, comments, anything you do differently. Happy to hear dissenting opinions. Put whatever you want in the chat box. Don't be shy. I will come back to this. There are a lot of two-drug options coming in the future. Here is a general description and estimated years of possible approval. I will go into more detail about some of these, but first, big picture. New two-drug oral options coming relatively soon. doravirine, the NNRTI, with islatravir, a novel NRTTI, is likely coming in 2026. I think not long after that, we will see bictegravir, lenacapavir. So these are both two-drug daily options. And what I want to ask you and encourage you to think about is who in our clinics would you prioritize for these new two-drug oral options? I don't think there's a right answer. I'll just encourage you to think about that. I've been pondering that, and I don't know that there's a right answer. Somewhere around 2027, we may see islatravir, lenacapavir oral weekly. So this is two-drug, once a week HIV treatment. Again, who would we prioritize for this? It's weekly therapy. As I was reminded recently with a discussion with our Kaiser colleagues, this is two totally new oral mechanisms of action. Let me say, for most individuals, this will be new mechanisms of action. Islatravir, again, an NRTTI, lenacapavir, a capsid inhibitor, currently available as an injection and not being used widely because currently there are relatively few individuals with an indication. But here, new two-drug oral options, some with very novel mechanisms, new two-drug weekly options, and then options that have a more questionable future, but I think we may see at least some of these. And again, I'm just going to step back and take big picture. Two-drug weekly options, two-drug oral monthly options, and two-drug injectable options potentially given every 3, 4, or 6 months. Now, there's questionable future around some of these. This first option of these two drugs, GS-1720 and GS-4182, are on hold. Interestingly, because of decreased CD4 and lymphocyte counts, similar to what happened with higher dose islatravir. And then these two-drug weekly options. I've used abbreviations here for time, but these are, NRTTI plus novel NNRTI options, new options with long-acting integrase. I really think the future is going to be two-drug options, prioritizing longer-acting integrase inhibitors, oral capsid inhibitors, and then combinations that also include two drugs with the NRTTI. That really seems to be the future to me. Again, I would love to hear from you. Should that be the future? Should that be the priority? And on the right here at the bottom, I'll just emphasize the possibility of HIV treatment with injections every 6 months. That, I think, would be huge. That could be a game changer if we could access it for the people who would benefit. I won't go through all these options in detail. If you have questions about them, I'm happy to field questions. But this is the general landscape for the future of HIV treatment. So the trends that I see being prioritized, two drug options. These options all avoid NRTIs. I'll ask you again, how important is that? And a lot of them prioritize non-daily therapy. I will also give the emphasis that with these options coming that avoid TAF and TDF, we will need to think about hepatitis B. I'm going to say that differently. It is going to become so important to think about hepatitis B. It's already important, but the more we use two drug options that avoid TAF and TDF, the more critical it is going to become. Let me show you a bit more about these options that are coming in the relatively near future. So this is a summary of the doravirine, islatravir, two-drug oral studies. Doravirine, again, an NNRTI, which we already have available. Islatravir, a new medication not yet approved that has a novel mechanism of action. It's an NRTTI, blocks reverse transcriptase in a different way than our current NRTIs and with multiple mechanisms, and seems to be effective even with NRTI drug resistance. There were studies of a higher dose of oral islatravir that were put on partial clinical hold because with that higher dose, CD4 counts and lymphocytes declined. There was no increase in clinical events like infections, but that was concerning. The trials were paused. Those individuals already in those trials were able to continue, and then trials were resumed with a lower dose. And I'll show you a bit more about this. You can see here towards the bottom of the table the ongoing trials using the lower dose of oral islatravir. So there is a switch to the two-drug option compared to standard oral therapy. There's a switch compared to continued bictegravir/taf-FTC. We've seen data for both of these studies. There's an ongoing trial for treatment-naive individuals, and there's an open label trial for those who started in the higher dose and now have switched to the lower dose. This trial up here called Illuminate HTE, where doravirine islatravir was added to optimize background therapy for heavily treatment experienced individuals, is not going to resume or be replicated as far as I understand, given the theoretical concern that individuals with more advanced HIV could experience the decrease in CD4 count and lymphocytes, and that could be even more impactful. Now, we will see what happens in the future in post-marketing experience, for example, with the lower dose of islatravir. I remember when we were all pretty excited about rilpivirine when it was being developed as this novel NNRTI, and then in trials, it led to prolonged QTC, and they kept cutting the dose down and down and down, and then it ended up being, kind of a wimpier medication than others. So we'll see what happens with the lower dose of islatravir. But the new drug application for this combo, doravirine islatravir, has been submitted, and we anticipate an FDA decision by April 2026. So we very plausibly could have this new two-drug once-a-day oral option within the next 6 months. Again, I would ask you who you might prioritize for this in your clinic. I'm just going to show one study. We saw primary data earlier. This is more recent data from ID Week. Here, the results of both the study 051 and 052 were pooled and combined. The first study was open label doravirine islatravir compared to baseline ART. The second was blinded with a comparison of the two-drug option to bictegravir/taf-FTC. The purpose of this trial was to look and see if there was any difference in efficacy or safety by these age groups. You can see here in the lower left with the clinical question being, in different age groups, is there any different effect on lymphocytes or CD4 count? And the overall message here is that regardless of age group, regardless of comparison, individuals in these trials did extremely well, and the therapy was well tolerated, and there were no deleterious or concerning effects on lymphocytes or on CD4 count. I've listed at the bottom some of the other data for this option. If you really want to dig into it, the primary data we saw in earlier conferences, there have been some studies of this option with known past NNRTI resistance, but fully active doravirine. The company developing this has been doing studies and is sort of trying to convince us that it's metabolically neutral and may be beneficial for individuals with metabolic comorbidities. I am not convinced of that yet, but there are studies of that out there. So again, which individuals will you prioritize for this option? I think we may have it available within the next 6 months. If you're willing to share.
Brian, the chat box is disabled, so that's why you're not seeing people in the chat, but over in Q&A, people are saying things. Just wanted to let you know that. I think people are eager to answer your questions.
Julie, thank you. That's why I'm staring at a blank chat box. I appreciate it. Let me see if I can pull up the Q&A. Give me one moment.
Sure, and I'm happy to tell you what's there. I think in terms of comments,
and Julie, I do have it now.
Okay, great.
Thank you for interjecting. I appreciate it. So I was not ignoring you all.
And most so far are questions, so you may want to just leave them to Q&A, but I think Glenna over in Answered pointed out that chat was disabled and did say, I think the Q6-month injections are probably the most interesting.
Thank you, Julie. Thank you all who have put in questions and put in answers. And thank you for alerting me that you were not all sleeping through my presentation and avoiding the chat box. So I will come back to the Q&A in a bit. Encouraging you to think about this question. We'll have a new option relatively soon. Who should we prioritize for it? Let me turn to oral lenacapavir. Maybe this is more exciting, and I really think we are likely to see a new drug application in the relatively near future and likely to see this option become available within the next 2 years. I've given you here a description of the phase 3 studies with bictegravir, lenacapavir, oral daily, Artistry 1 and Artistry 2. I will show you some of the earlier data for Artistry 1. We also recently learned, without seeing full results, we recently learned that Artistry 1 phase 3 met its primary endpoints. I anticipate we will see complete results at an upcoming conference. Artistry 2 phase 3 is ongoing. And then here, weekly oral islatravir, lenacapavir. I'll show you a little bit more data on that as well. Again, Artistry 1 is a switch to daily oral bictegravir, lenacapavir. I anticipate in the future that will be combined into one pill. In these studies, it was given as 2 separate pills. This was the phase 2/3 open label trial. You can see on the left who was enrolled. The comparison here is daily bictegravir, lenacapavir oral versus bictegravir TAF-FTC. Here you can see 2 different dosing. I'm going to say that differently. Here you can see 2 different doses of the oral lenacapavir being studied. The len 50 milligrams daily is what moved forward. Again, we've not seen full data from the phase 3 trial, but we will relatively soon. I like this study because it was a switch to this 2-drug once-a-day option for individuals who are taking relatively complex regimens. You can see here on the left a description of the participants. Many participants were taking ART twice a day. Many were taking more than 5 pills a day. The max was 11 pills a day. I mean, really 11 pills a day going down to 2 in this trial, or what will be 1. And individuals were randomized 2 to 2 to 1. Here's the virologic efficacy, and the punchline is that the efficacy was extremely, extremely good in all of the arms, and the bictegravir len with len 50 milligrams is what will be going forward. Let me show you some data of oral weekly ART. This one earlier in trials, this is the phase 2 data, but my understanding is going into phase 3. Again, oral weekly with mechanisms of action that the majority of individuals will not have been exposed to in the past, islatravir and lenacapavir. You can see the entry criteria on the left, and on the right, you can see that there's a randomized phase and then an extension phase. The data we've seen so far are the 96-week data for what I've put in the red box here, the islatravir with lenacapavir oral weekly. Again, this is the lower dose of islatravir that does not seem to cause all of the laboratory side effects as the original higher dose. Again, we're only seeing data here from 96 weeks in that single arm, but it was both effective and very well tolerated. So the potential for weekly oral HIV treatment in the future with mechanisms of action that the majority of individuals will not have been exposed to in the past. I'm only going to mention this relatively briefly. A lot of you have heard me talk about this. I am not convinced that integrase inhibitors truly cause weight gain. I am not convinced that TAF truly causes weight gain. Obviously, there's a correlation. Obviously, there's a difference when you compare integrase inhibitors to older meds like efavirenz. Obviously, there's a difference when you compare TAF to TDF. I am not convinced there is a direct causation. Because we're mostly focusing on two-drug therapy, this is what I'm going to show you. At IAS 2025, we saw what is probably the most robust data for answering the question of whether a switch of ART truly affects weight and BMI and metabolic comorbidities. That trial for which we were a site and which is most commonly known as DO-IT is really notable. I decided not to review it here simply for time, and we have pretty thorough reviews of it on our Echo, our Project Echo Talk streaming channel on YouTube. And if you want links or any further data, feel free to reach out to me. Feel free to reach out to RBI or others at UW Positive Research who were really instrumental in enrolling and helping complete that study. Again, I'm focusing here on switch to two-drug therapy, so I will just mention in the studies that looked at weight change in a switch to two-drug therapy, dolutegravir versus uh, versus continuing three-drug therapy, what we saw was that stopping TDF can lead to weight gain. There was no consistent pattern with stopping TAF. Stopping TAF did not consistently lead to weight loss. And I think that's been pretty consistent. If we look at other trials of switching to two-drug therapy like dolutegravir, like cabotegravir, or even the upcoming doravirine islatravir option, again, there was no consistent finding. I'm going to say that differently. Stopping TAF did not consistently affect weight in any predictable way. So the HHS guidelines and also the IAS USA guidelines provide these updates and really emphasize that for the majority of individuals, weight should not be a reason to delay ART or pick specific ART regimens. Now, there certainly are unique cases in which that needs to be considered. There certainly are unique cases in which a person is really distressed by their weight, and the correlation really seemed to be, the timing really seemed to be with starting ART, and it may be worth a switch to see if it helps. But in my experience, in the majority of instances, it does not lead to a major benefit. So here's my overarching question for you. The future is two-drug ART. That really is the trend that I am seeing. Is that really better than three-drug ART? I don't know the answer. Should that be the priority? How much will we be using existing two-drug therapy? I mean, let's just take dolutegravir, for example. Lamivudine is currently generic. Dolutegravir is not. We have a combo pill that has become easier to access, or we can do dolutegravir with generic 3TC. And within the next 5 years, dolutegravir will probably become available as a generic as well. I've tried to figure out exactly when, but those patents end sometime between 2027 and 2030. So within the next 5 years, maybe we will have generic dolutegravir. Will that make a difference? Will the coming options that I showed you that are in the pipeline that will be theoretically available within the next 1 to 2 years, will those make a major difference? Should that be the priority, or should something else be the priority for ART development as we go forward? These are my conclusions, and then we'll have some time for questions and comments, and I will do my best with those. I've mentioned that first point. I'm posing that second question to you because I really don't know the answer. The future seems to be avoiding NRTIs. I'm yet to see a study comparing two-drug therapy avoiding NRTIs to three-drug therapy with NRTIs that really is convincing that there's long-term benefit. But theoretically, NRTIs have, especially the earlier ones, have had a lot of side effects and toxicity, and there may be toxicities we don't understand. And I'll come back to this point of remembering hepatitis B as we get away from TAF and TDF, as we use more of these options, as there are more options coming in the future that avoid those meds. so critical to think about hepatitis B. I'll give a plug to our colleague Nina Kim, who has done some fantastic talks and other education about considering an isolated hepatitis B core antibody, which is absolutely important to consider as well. And then we may, in the relatively near future, see once per week oral ART treatment, and we may see other long-acting injectables and non-daily therapy. Obviously, there's a caveat of who we can get these for in terms of cost and access. But let me pause there, show our acknowledgement. Feel free to email me with questions, comments, or complaints about anything I said, and happy to do my best to field questions and comments.
Great. Brian, thank you so much. If it's okay, I'm going to group some of them for
Yeah.
you and invite people to answer Brian's question. And Victor, I'm going to ask you to please save the Q&A if we don't get to everything since we've just got 9 minutes. So feel free to put more questions in and comments answering Brian's questions. So a few about injectable ART, two focused on right now. So one was about if you could talk a little bit about injection site reactions, especially after several years of treatment and the indurations or nodules, what do we know about that? And then the practical issue of are there barriers to third-party payment of long-acting injectable cabrylpivirine? And do you have any suggestions for successful prior auth?
First, I will acknowledge that there are others in the clinic who have more experience on these things than I do. So if anyone watching would be willing to weigh in, please do, especially on the prior auth and access issue. I'll make a couple comments about that, but again, others will be more adept at giving you specific advice and solutions. First, on the injection site reactions, uh, in my experience for patients I have receiving IM cabotegravir pivirine, the injection site reactions can be pretty painful. It is mostly pain. There are descriptions of ways to reduce that. With injectable lenacapavir, the subcutaneous injections, our experience is relatively limited so far, but there can be both short-term injection site reactions, redness, pain, a little bit of swelling, and there are descriptions of how to help reduce that, some topical numbing medicine before the injection, ice after the injection, and luckily those are short-lived. The nodules are different. And as I've talked to people, the nodules can last a while. And I think it is less clear how to prevent or manage the long-term nodules. We have a guide on the National HIV PrEP curriculum that myself and others spent a long time developing. It gives instructions on the injection technique. It is really key not to get it into the intradermal space and to use appropriate injection techniques. But even with that, people can develop relatively chronic nodules. I think it's something we need to counsel people about. I've heard a little bit about massage after developing the nodule, but I think they can be persistent. I was presenting at a conference last week with a really fantastic pharmacist who said that she just asks people, where would you most like a nodule if it does happen? If people are wearing short shirts or whatever it is, she simply asks people and tells people, hey, there may be a nodule. Where would you most like it if it happens? But I don't think there is a really clear way to manage those. If others know more, please weigh in. On the cost and access issue, I think it is complicated. I think because the long-acting injectables are often considered a medical benefit, not a pharmacy benefit, you need to look into your clinic's policies and whether it is buy and bill or white bag or brown bag or whatever it is. And I think you do need to be persistent, and I think it can take a team and a lot of resources. I'll leave it at those general comments, and we have others in the clinic who have much more experience with that than I do.
Great, thank you. How about a couple questions about the future of injectables? So one of those is, are there any current trials of 6-month injectables for people with poor med adherence that are open now? And second is, do you know of any implants for treatment in development?
Fantastic question. For the question about current trials enrolling, if RBI is on, would love RBI or others from the UW Positive Research to weigh in on that. The trials I know that we're enrolling, like Crown, are not fully 6-month regimens, but obviously there are other 6-month long-acting injectable options being developed, I'll look to colleagues, or if you want to look at the UW Positive Research website, trials are listed there. What was the second part of that, Julie?
Do you know about any
Implant.
implants?
Implant. I have not seen implants as part of HIV treatment. I have seen early data for implants for PrEP, but if anyone knows additional data about implants for treatment, please weigh in. I think the implants, at least my impression is the implants are being prioritized more for PrEP than for treatment.
Great. All right. Question from David Hatchie, which I think you sort of answered. He typed it before you got to weight gain, but want to give it a chance to emphasize it. Without knowing long-term side effects of the newer agents, would avoidance of weight gain be a reason to start or switch to two-drug therapy?
Dave, thanks for the question. I think the question comes up a lot. And from what I have seen, no, I don't think it should be a priority. I think that what we have seen is that in the majority of switches to two-drug therapy, whether it's dolutegravir, lamivudine, cabotegravir, rilpivirine, or newer options, individuals do not tend to lose weight or have improvement in metabolic comorbidities. We will see what the future holds.
Thank you. Question from Rod Gordon. In Artistry 1, why was 75 milligrams of BIC used?
Thanks, Rod, and thanks for watching. I couldn't quite figure that out. Maybe because it's two-drug therapy instead of Big TAF FTC. I think what Rod's getting at is in Big TAF FTC, I think it's 50 milligrams of bictegravir, but in that trial it was 75. Rod, I don't totally know the answer.
And then a question from Michelle Burton. How are these two-drug therapies tolerated with TB and LTBI
The
therapies?
therapy, such a good question. I don't totally know the answer. I don't know how much has been looked at with these new therapies and, for example, rifamycins. I can look and see if I can find anything about that. I don't know off the top of my head.
Great. And then someone commented on the question of expense and said, I'm curious how expensive many of the new options will be. And if we have more options, will it just get more confusing to decide which option to use again?
I think the expense, the cost, the access is always an important consideration. I think, as you probably experience, when things are new, it takes a while for them to get on various formularies, and sometimes they can require prior authorizations, especially for insurance companies that tier the options. So TBD, I expect it will be an important consideration soon after the options are approved.
Great. And a comment from Rod saying, I think the question isn't whether a two-drug regimen is better than three drugs, but are they equally effective in different clinical scenarios? Because if they are, then it allows us to give the patient more choice and voice in their treatment options, which will result in better adherence and treatment outcomes in the long term.
Rod, point totally taken. Thus far, the efficacy data looks really promising, and your point is totally taken. And circling back to the prior comment is just going to make things just more complex and confusing, maybe in a way, but I really value having options and being able to work with an individual and figure out the option that is best for them. So hopefully, more choice will mean more empowerment for individuals to pick what is best for them and what they'll most likely succeed with.
That's an excellent point, and I think a great note to end on. I'm going to give you a moment, Brian, to give some closing words, but thank everybody again for joining. And thank you, Brian, for giving such an excellent talk that I think we all learned so much. And as always, this is one of the most popular talks of the year. So thank you. And what do you want to leave us with?
Thank you all for your time. If you have other questions or comments we didn't get to, feel free to email me. And thank you, Julie. Thank you for the AETC team for all you do to organize these. Thanks, everyone.